For the introduction, and like to thank Bansi Sabu, Dr. Jyotidev, and Dr. Krishna Sheshadri for this opportunity. I'll just start off with the topic with the introduction, which is diabetic neuropathy is probably the most common complication of diabetes when you look into it. And if you look at diabetes neuropathy as an entity, if you look at neuropathy as an entity, diabetes is probably the most common cause. It may be present even at the first diagnosis of patients with type 2 diabetes, especially it can present with just a peripheral neuropathy, with a hyperglycemic neuropathy, or with some things like amyotrophy. And even in patients with type 1 diabetes, studies have shown that around 30% of unselected patients in the Eurodiab did have diabetic neuropathy. So it's very important to note the original definition of diabetic neuropathy, in which it says certain conditions that the condition should be a demonstrable disorder, either clinically evident or subclinical in the setting of diabetes, without the cause of peripheral, without any other cause of peripheral neuropathy. So basically, by definition itself, diabetes neuropathy implies that you should be excluding other causes of neuropathy before you say it's diabetes neuropathy. So what is the importance of identifying and treating this disorder? Quality of life issues. You all know that as treating physicians, when you have a patient with severe diabetes neuropathic pain, this is one of those things which really impair the quality of life and the sleep of your patients. Foot ulcers, foot deformities, Charcot's foot, and probably among patients with amputations, diabetes forms the number one cause of non-traumatic amputations in practice. So there are a lot of reasons why you should be identifying diabetes and diabetic neuropathy. Now, coming to the classification of diabetic neuropathy, just a disclaimer before I go further that I'm not a neurologist, I'm just an endocrinologist, so there'll be limitation in terms of what, but I'll just take you through why is it important to make a differential diagnosis. So look at the classification of diabetes neuropathies. You need to divide them into symmetrical neuropathies and focal and multifocal neuropathies. And probably the most common of all this, which you see in clinical practice, is the symmetrical sensory motor distal peripheral neuropathy, with or without autonomic neuropathy. And then you have other neuropathies which are symmetrical, like the hyperglycemic neuropathy, which is associated with severe hyperglycemia. You have the acute painful sensory variant of this, where you don't have any neurological findings as such. You have a normal nerve conduction velocities. And coming to focal and multifocal neuropathies, you have things like cranial neuropathy, focal limb neuropathies, thoracolumbar radiculoneuropathy, which presents as a sort of thoracic pain. And you have an entity called lumbosacral radiculopathy. I'll come to this later. So you have different forms of neuropathy in clinical practice, and most of my talk will concentrate on the differential diagnosis of the first part, that is a symmetrical distal peripheral sort of neuropathy which you see in practice. This forms the 80% of patients whom you see in practice, and the symptoms usually start in the lower limbs. It starts usually as numbness, burning feet, pins and needle sensation, and lightning pains. It's more pronounced in the night. You will certainly see certain patients with small fiber neuropathy, where you have pain, burning, and all these typical features of neuropathy, but when you put the patient through an examination of deep tendon reflexes, or you do a vibration perception threshold, you end up having a normal feature. These are small fiber neuropathy, which is one of the earliest form of neuropathies in patients with type 2 diabetes. And then you have the large fiber neuropathy. That's a progressive, it's a demyelinating form, where you have a deep pain, numbness, ataxia. This is the sort of neuropathy where you have a loss of motor function and you have absent deep tendon reflexes. These are the patients which usually get detected with your vibration perception or monofilament testing, which you have in practice. So it's important to realize that you may not always have your clinical examination positive in a patient with diabetic neuropathic symptoms. You may have a subclinical, or rather your investigation modalities may not be good enough to detect a small fiber neuropathy in patients with diabetes. Now, running through the other neuropathies, cranial neuropathy, we know that it's quite common in practice. Focal neuropathies like entrapment neuropathy, like carpal tunnel syndrome and tarsal tunnel syndromes are common. Mononeuritis, you can occasionally have a patient with a foot drop or some mononeuritis coming in. Truncal radiculoneuropathy, truncal pain along dermatomal distribution, hyperglycemic and autonomic neuropathy. This is a general classification of neuropathies. This is just a picture to show you that when you look at a patient with diabetes and neuropathy, what you diagnose as symptomatic neuropathy is probably the tip of the iceberg. And you have a significant amount of neuropathy, which you may again pick up with clinical examination. you pick up with other electrophysiological methods, and you can also have more modern methods like corneal confocal microscopy and things like this to pick up minor varieties of neuropathy. So basic things that you may not have the entire spectrum of neuropathy being picked up in your clinical practice when you do your routine examination. And what is a routine examination looks like? It's a general examination which you have been taught in undergraduate days for examining the nervous system in terms of going through the entire visual inspection, the examination of all this touch, position, all those things, looking at deep tendon reflexes, looking at autonomic dysfunction. But one thing to take home is that to do a differential diagnosis of diabetic neuropathy, you need to run through at least a basic set of this clinical examination before you can decide what sort of neuropathy you are dealing with. Now coming to the main part of my topic, it is that not all neuropathies in diabetes is diabetic neuropathy. That is something which we need to understand. If you look at different studies like the Rochester diabetic neuropathy study or studies from the US, it has been shown that certain studies, up to 50% of patients with diabetes may have an alternate reason for neuropathy. It may not be the hyperglycemia alone as a cause of neuropathy. And this is the reason why you need to make a differential diagnosis or to have a basic secondary workup for patients with diabetic neuropathy to make sure that you are not missing any of the potentially treatable causes of neuropathy in these patients. This is the entire list of neuropathies which you find in textbook as the reason. And I'm not going to elaborate on each and every aspect of this differential diagnosis, but rather I'll concentrate on 3 different clinical cases and try to explain why it is important to look at certain points when you do a differential diagnosis. And why is the differential diagnosis important? Because the first thing is that these patients may have another cause of neuropathy which is potentially treatable or reversible, like having a nutritional deficiency or having a hypothyroidism which is potentially treatable and reversible. Or you may be having an underlying major disorder of which neuropathy may be the initial presenting symptom. You may have a paraneoplastic neuropathy, you may have an infiltrative disorder, you may have a vasculitis which comes to you as just a neuropathy, and that will form the initial point of diagnosis or the initial point of a differential diagnosis where it leads on to another more serious outcome. Cranial neuropathies can be a sign of an intracranial space-occupying lesion like a posterior communicating artery aneurysm or something which presents with a neuropathy, and then you work on it and finally realize that even in a patient with diabetes, there can be another cause of neuropathy which is very important to identify. I'll just go through 3 cases. These are common sort of stereotypical cases, but not the real ones. So this is an 18-year-old lady with type 1 diabetes since 8 years. She's on basal bolus insulin. She's reasonably well controlled over the last 2 or 3 years, around 7 to 7.5% A1Cs. She's got hypothyroidism. She's on L-troxin. TSH has been around 2 to 3, reasonably well controlled. She complains of painful paresthesias of feet and imbalance while walking since last 1 year. There's no nephropathy, and there's no retinopathy. And on clinical examination, she's got the typical absent angle jerks, impaired position and vibration sense. She's got an extensor plantar and a normal muscle power. This is a patient who has come to you, and this is the time when you examine a patient with diabetic neuropathy or potential diabetic neuropathy, you need to look at the red flags. And that's the reason why you should refer certain cases and keep certain cases with you. So what are the red flags in this patient? This is a patient, a younger patient who is not supposed to have that higher risk of neuropathy, but having type 1 diabetes, younger one, having one autoimmune disease. She's got autoimmune hypothyroidism, which actually will make you think that whether she's having another autoimmune disorder. She's got she does not have retinopathy or nephropathy. It's quite unusual for patients with type 1 diabetes to have significant neuropathy in the absence of other diabetic microvascular complication, unlike type 2 diabetes. So again, which makes you think that whether you're dealing with another reason, and an extensor plantar, which is almost not seen in diabetic peripheral neuropathy routinely. And this patient has been subjected to investigation. You can see the B12 levels, which are very low, the folate levels, which are normal, the ANA, which is negative, the celiac screen, which is negative, peripheral smear, which is normal, and the antiparietal cell antibody, which is positive. So basically, you are dealing with a patient with vitamin B12 deficiency and having symptoms of neuropathy rather than a patient with a neuropathy related to diabetes. So this patient got treated with vitamin B12 and folic acid, and the patient had an improvement. Now, just to take one slide on B12 deficiency. B12 deficiency primarily involves the dorsal columns and the lateral corticospinal tracts. And so these patients do have a combination of both peripheral neuropathic signs as well as upper motor neuron signs. It can be associated with a lot of diseases where B12 malabsorption can be there. I just highlighted one condition, but there can be other patients with adults with similar picture. It is reversible in early stages, and one important thing is that you cannot do a peripheral smear and look for macrocytosis or anemia to see that whether the patient has got a B12 deficiency, because patients with B12 deficiency can have a dyssynchrony. They can have normal blood parameters and an abnormal thing, and even you must all be aware that even B12 levels by itself is probably not an ultimate diagnostic tool in diagnosing B12 deficiency. There are other things to be discussed on that. I'll leave you here, but the take-home message is that in patients with type 1 diabetes, always suspect B12 as one of those differential diagnoses. This again, imaging to just show you the MRI images of a patient having a certain degree of demyelinating patches here, showing that posterior means the tracts are involved in these patients with B12 deficiency. Now coming to the second case, this is a 70-year-old gentleman with type 2 diabetes in 6 years, on Mixtard, quite well controlled, reasonably well controlled, I should say, no other complications, known to have numbness of feet since 1 year, like it's the typical sort of patients where you will think about diabetic neuropathy as the only diagnosis. But when you go further into the history, you see that since 6 months he has got problems with fine movements of the hands. Clinically, he's got some small muscle atrophy in the hands. Reflexes are lost, upper limb reflexes lost, biceps supinator reflexes. Triceps, he's got hyperreflexia, and knee jerk is hyperreflexic. There's a mild increased tone in the legs, plantar is extensor. Again, these are patients where if you stop at numbness of both feet, you are stuck there. But when you go further into the history, you realize, and the examination, you realize there's certain points which make you think that you may not be dealing with a patient with pure diabetic neuropathy. So having an upper limb involvement before significant lower limb involvement, again, is a sign whether you should be looking at different other causes. Significant motor impairment in comparison to sensory impairment. Upper motor neuron signs like hyperreflexia, increased tone, extensor plantar, these are all features of upper motor neuron disease, which is not very typical of patients with diabetic neuropathy, and that's the reason why these are the red flags which have been raised. So this patient has a cervical myeloradiculopathy, and you can see multiple disc compressions at the cervical levels, which again makes the reason why you have a combination of upper motor neuron and lower motor neuron sign this patient, think of another cause, think of cervical disease. Now coming to the last case, it's a 50-year-old gentleman with diabetes since 5 years, on insulin oral hypoglycemic agents, peripheral neuropathy documented. We all do vibration perception with the biothesiometer. It's a very useful test, so it's already been documented to have diabetic neuropathy. But he's been unable to hold slippers since 4 months, again, quite common with diabetes patients. Leg paresthesia is worsening over 4 months, difficulty in climbing stairs and getting up from chair, quite unusual for a patient. Proximal muscle weakness, proximal nerve involvement, no bowel bladder, absent ankle jerks, knee jerks, plantar is flexor, proximal and distal muscle weakness, hypotonia. So this is again a patient with very high involvement of motor system. And he's got relatively, I can't say rapid progression, but subacute progression of symptoms. Predominant motor involvement, significant proximal muscle involvement, profound areflexia and hypotonia. These are all features of another disease where electrodiagnostic test has been done by the colleague neurologist and been found to have a CIDP. So when you look at this red flag signs, again, it's time to think that you are dealing with something other than the pure diabetic neuropathy that you have in practice. So just to run through what CIDP is, it's an immune-mediated demyelinating neuropathy. There is some data to show that patients with type 2 diabetes have an increased predilection for developing CIDP. Even though you say it's a sensory motor neuropathy, motor symptoms grossly predominate. You may have significant proximal muscle symptoms. And the best thing of all is that this is a potentially treatable condition with corticosteroids, IV immunoglobulins, or plasma exchange. So this is the importance of identifying a reversible condition or a potentially treatable condition in clinical practice where you can interfere and get improved results. Next comes a condition called diabetic amyotrophy, which is now called diabetic lumbosacral radiculoplexoneuropathy, because you have a ischemic damage to nerves from multifocal immune-mediated microvasculitis. So it usually starts unilaterally, spreads bilaterally, and one of the cardinal points is that you tend to have pain in the hip, buttock, and thigh with weight loss. So it's sometimes called a diabetic cachexia, cachexic neuropathy, and things like that. There is significant muscle wasting. It may be asymmetric to start with. knee jerk is absent, there are no upper motor neuron signs, there's no usually bladder bowel involvement, and the clinical course is 3 months, 6 months to 3 years. But when you look at diabetic amyotrophy, again be careful. You should always think of other differential diagnosis of radiculoplexoneuropathy, like an infiltrative disorder which is happening in the lower sacral regions, a paraneoplastic syndrome, a vasculitic syndrome. These are all differential diagnoses. You will see demyelination in the nerve conduction, and patients with these demyelinating features are potentially treatable again with steroids and IVIG, giving them tremendous relief instead of going through the natural history of 3 years. Always think that these patients can have potentially have a spinal lesion which may be amenable to surgery, and always go for imaging in these patients and exclude CIDP again when you see a diabetic amyotrophy. So these are all differential diagnoses where you have different other causes of diabetic, means non-diabetic etiologies when you see patients. So do you need any basic workup for patients with diabetic neuropathy? Probably for a patient with a very, very typical diabetic neuropathy, you may not require, but there is some recommendations which has come up earlier, which says that it is good to have, if you have some atypical features of diabetic neuropathy, you should probably investigate these patients, at least have some basic things done for reversible reasons. Look at B12 and folate levels. Look at a serum electroporation. You have paraproteinemias and monoclonal gammopathy associated neuropathies. Look at vasculitic etiology, thyroid functions, counts, ESR. LFTs. So if you see anything which is shortly grows out of, you can look at creatinine, renal dysfunction, and uremia is another cause of neuropathy. So if you see anything which is beyond the normal thing, please refer the patient or get an opinion from a neurologist. So who should have nerve conduction velocities for patients with diabetic neuropathy? Nerve conduction velocity is not an absolute requirement for diagnosis or treatment of diabetic neuropathy, as you would all know. But if you have predominant motor or substantial motor involvement out of proportion to sensory involvement, go for a nerve conduction. If you have a family history, you may be dealing with something like a patient with Charcot-Marie-Tooth disease or something like that. Entrapment neuropathy is suspected. You have asymmetrical, you do a vibration perception. You have one leg having normal vibration perception, other leg having absolutely poor vibration perception, time to go for a nerve conduction. Rapid progression of symptoms over months. Asymmetric neuropathy, disproportionate upper limb involvement, these are all conditions where you have nerve conduction velocity. And it's also for certain parts of India, you need to look at leprosy as a differential diagnosis. Quite common to have that again as a differential diagnosis in certain patients. So when do you think beyond neuropathy, diabetic neuropathy? Again, the same things, I'm repeating it again so that you go through the system because it should be more clear. Rapid progression of symptoms, motor predominant neuropathy, autonomic symptom predominance, very rarely seen without peripheral sensory neuropathy in diabetic patients, bowel bladder involvement, proximal muscle involvement, disproportionate upper limb involvement. These are all signs that you may be dealing with some other reasons. The carry home message will be diabetes can affect different parts of the nervous system. Not all neuropathy in diabetes is diabetes neuropathy. Look for certain red flags, signs and symptoms which I told you earlier. Do basic investigations and nerve conduction when indicated, and refer to neurology when in doubt. For me, any atypical patient with diabetic neuropathy is a patient in doubt and gets referred to a neurologist for opinion. Thank you very much. I leave you here.